Hi, and welcome to this week's summary lecture. Today we're just going to be talking about a small part of Chapter 12. I kind of wanted to cut it short for a couple reasons. First of all, I actually love all the conversations in the chapter, but some of them are a little too nitty-gritty, I think, for this survey course. Although I encourage you to read the chapter, and if you want to talk about some of the specific issues like universal health care or medical marijuana and those types of things, I encourage you to bring them up again on the discussion board if you want to sort of get into those issues a little bit more deeply. The other reason I thought it would be nice to have a little bit of a shorter session, and also you'll notice some of the things we're going to talk about as kind of a review, is because it's your exam week, and I thought it would be better to just cover something that you're already a little bit familiar with, which is why what we're going to be talking about is issues that we've kind of been talking about for most of the semester already. Issues about health disparities and also stigmas that plague people in different health communication contexts. So let's just sort of like go over the main points. I'm starting really to talk about some of these issues. Sorry, I'm going to find the page here. We go to, yeah, right in the little subsection, it looks like here on 314 is where the content starts that I really want you to focus on. And again, this is a type of theme that we've talked about quite a bit already, but just to summarize it, I love that your book in that first little sentence in this section says, unfortunately, who we are, where we live, and how much money we make directly influence our access to quality healthcare and our political power to make changes to the healthcare system. Honestly, if you take anything away from this chapter, that's what I want you to take away. 3 points here: who we are, again, who our identity is, what sort of groups we belong to, where we live, so geographic concerns too, and how much money we make. So obviously, if we can afford different types of healthcare, or I should mention healthful situations, right? That's all going to affect not just our access to getting good healthcare, but also just our general overall health. Some of the examples I wanted to bring up to sort of nail this home is, you know, as I've mentioned several times already, I did a lot of research working in urban environments in the city of Atlanta, where access to healthcare, you've heard me talk about, is a big deal. That's why we had a lot of people using the emergency room for primary health care, because due to financial reasons, people of lower income, and also a lot of the people that I would work with were African Americans, right? There was all sorts of reasons why they weren't able to have a lot of the same primary care access. Some of it had to do with the jobs that they were working and the types of insurance that they had, but also it was somewhat geographic too, right? They had one huge downtown hospital, but maybe not all the urban care facilities. But another thing I wanted to bring up as far as the ecology goes, when we talk about like different environments, is that they also had problems just maintaining their health. It wasn't as easy for them, for instance, to find fresh fruits and vegetables, because in their neighborhoods, right, nobody wanted to put like the nice grocery store where you could get those. There was no Whole Foods in these neighborhoods, right? What they had access to were convenience stores that sold not only like nasty fruits and vegetables that nobody would want to have, but also things that were bad for their health. So, you know, alcohol and cigarettes, and, you know, it's kind of a cyclical in that way, because you would have people engaging in negative health behaviors, and then the types of health opportunities that the community would support were also not very good. I think that's a good example of, it was somewhat linked to who they were, but also very much linked to how much money they made and also where they live, right? All of these things were sort of intertwined. This is another really important issue, I think, to think about as far as West Virginians go, right? West Virginia is not a rich state. It also has a really very high rate of obesity, I think second only to Mississippi. Sometimes that changes, but I'm probably pretty close. Somebody can check me on that. And when we think about the reasons for that, right? What are the factors that make West Virginia and Mississippi, probably very similar, different from the rest of the nation, where they have this high risk rate for this health behavior? One of it could be access to care, right? We have a lot of people living in rural environments. We have financial issues in our state, and we also, of course, have stigma attached to West Virginians. Nobody cares about West Virginia, right? So that leads to different like policy outcomes and all sorts of things. This is not, by the way, to take away from arguments about the individual. It's just to say that individual decisions are also sort of linked with all of these other, I'll call it decisions linked to the greater ecology of healthcare. And people who study health disparities try to look at all of these different factors, right? On the individual level, but also on the societal level, linked to things like income and, income and geography and identity, right? But when we use terms, I saw the book kept using the term disadvantage. That's what we mean, meaning like there are certain advantages that you can have that will put you in a better position to get healthcare, and certain things that can make you disadvantaged. So I think that's a good way of looking at it. And we've talked about a lot of different things that can contribute to these disadvantages. Your book brings up several. Social discrimination, we've talked about this before when we've talked about older adults, even, for instance. Remember the predicament of aging model, and how it's not an overt type of discrimination where it's like, oh, we don't want to help older adults. It's not that. It's quite the opposite. It's just how we discriminate and treat people differently based on who we think they are. Local economics, kind of like the vegetable example I had, right? Sometimes communities can't sustain different types of health opportunities because of the financial situation. Education's a big one too, though, right? We know we have disparities in education. Some people have come from better school systems or better schools. Maybe that's linked to finances too, but that's going to affect other things like health literacy. So even if people have access to different types of healthcare situations, the question is, do they have the tools, like the education tools, to take advantage of them? And political power, that was mentioned in that very first sentence in this little section of the book on health disparities, and I really liked it because it's not just about quality healthcare, it's also about political power to make changes when healthcare is not going very well. And that leads me to sort of this other discussion in the other section of stigmatization, which we've also talked about a lot when we were talking about social support for people who maybe had a stigmatized illness like an STD or a mental illness. If you're stigmatized, right, and your condition stigmatized, then that naturally makes it more difficult for you to advocate for changes. Part of this is maybe a blame the victim mentality, where, you know, if people are in a bad situation, if people have the type of disease that is somehow socially undesirable, right, we tend to blame the person for it. Oh, if you have HIV/AIDS, well, that's because you're sexually promiscuous, whether or not that's the truth or not. But the sad thing is, getting back to this as a political issue, is if people don't feel like they can speak up and advocate for themselves or on behalf of other people with stigmatized illnesses, then we have systematic problems. For instance, like the fact that we have prisons full of people with mental illness, but we have very little treatment for them, and we don't have support. Let's say, you know, our insurance, our health insurance doesn't consider mental illness in the same light that it considers physical illness. And I'd like to point out also, because I realize I kind of wanted to stay away from politics, so to speak, and I don't mean to make a political issue out of any of this, but the reason why this isn't just a partisan issue, and I'm not even talking about healthcare funding more generally, but we take issues like mental illness and the support, you know, the policy support that we give for that, it's really something that affects everybody, even on a financial issue. Your book mentioned, let me see the statistic here, yeah, we actually, compared to everywhere else in the world, we spend more on our healthcare systems, and yet we're ranked 37th. When we have healthcare disparities, whether it's because of stigma or because of other different types of inequalities, that's not necessarily something that just affects the people with those illnesses, right? That's something that can affect all of us because we end up paying for it in some way, right? They might not have quality healthcare until the end of their life, but somehow it all goes back into the system, right? So I shouldn't even say we. I feel so bad about that, you know, or they. I should say like we, right? Because all of these issues affect us on some level. One more point. Sorry, I wanted to sort of skipping around here. I just wanted to make about that blame the victim, you know, it doesn't, I keep bringing up the same examples, but it doesn't just affect those classic, you know, sexually transmitted diseases or even mental illness. It's also about things like cancer. I think about how we think about lung cancer, getting back to this blame the victim. If you hear that somebody has lung cancer, right, we do tend to automatically assume, oh, well, they're a smoker. Didn't somebody tell you to put down the cigarette? And that may be true. It also might not be true. Quite a few people, for instance, with lung cancer never picked up a cigarette in their life, but might have it because of other environmental issues or even genetic issues. And I like that example because I think that really gets at the heart of the problem of stigma. We like to blame the victim. It's very easy to say that if somebody has something nasty, it's probably because of something they did. But that's not always true. And that's why I think that we as a society have a sort of an obligation to work to get beyond these negative perceptions of different types of health and disease issues. Because at the end of the day, I think it will affect all of us. I think that pretty much covers it. As usual, I talked a lot longer than I wanted, but look at that first sentence again. I think it's perfect. So, thanks.